So this year at the ASCO meeting in Chicago, Sarah Cannon was proud to have 50 of its abstracts accepted for presentation. We submitted 63, and the high acceptance rate just shows that we're studying the agents and we're conducting the clinical trials that are most relevant to improving the care for our patients. These 50 abstracts actually cover most of the various tumors that patients experience and develop, ranging from brain tumors to lung cancers to prostate cancer and breast cancer. So the breadth of the Sarah Cannon program is quite unique in that regard, and that's something we're hoping to share with our colleagues in the UK. Furthermore, we are beginning to study subsets of cancers. So not all breast cancers are the same, not all lung cancers are the same. And we're finding more and more that there's very specific mutations or very specific targets that can be identified for which a drug is particularly effective. At Sarah Cannon, we had the good fortune to study a class of agents known as PI3 kinase inhibitors. That's a fancy term for one of the common pathways that go awry, that cause tumor cells to be able to grow rapidly in patients and spread. The ability to target that pathway and cut off that growth supply to the tumor, to stop the ability of that pathway to proliferate, enables us to cause the tumor cells to quit growing and to, in fact, die. We were able to show with the use of a PI3 kinase inhibitor that we were able to have reductions in many of our patients who had actually had standard therapies and now had moved on to this in the latter stages of their disease. We had patients who had been on 5 and 6 prior therapies for their breast cancer have their tumors shrink dramatically. We also saw this with several other tumor types, to include patients that had melanoma and colon cancer. Some of the agents that were studied and presented this week at the ASCO meeting in Chicago hit some of the very common targets, some of the problems we know that cancer cells can develop that cause them to spread in patients. Now that we've identified the best dose and the best schedule, and we have some idea of where these drugs work, now they'll move on to the next stage of testing. So they'll leave the phase 1 arena and move into phase 2 and phase 3 clinical trials, where they'll either be added to standard of care or compared with standard of care to better ascertain the actual advantage that they provide.